Thank you to the program committee of SAGES for the opportunity to talk about the time and place for laparoscopy in the trauma patient. My name is Angie Ingraham, and I'm an assistant professor at the University of Wisconsin in Madison. I have two disclosures. One is that I do serve as a clinical consultant for the American College of Surgeons, and I do have a Career Development Award from the Agency for Research, Healthcare Research and Quality, both on emergency general surgery topics. Just as a little bit of background information for this talk, I am going to be talking about and focusing on adult trauma. There are some studies on pediatric trauma and the use of laparoscopy, but I'm going to be focusing on adult patients. We also are going to be talking primarily about acute trauma. So if someone had a diaphragmatic hernia from a trauma 10 years ago, it's not necessarily talking about it in that scenario, but how do you treat acute traumatic diseases with laparoscopy. And then finally, I'm going to be focusing on literature within the last 10 years. So there are several National Trauma Data Bank studies that look at laparoscopy versus open surgery for trauma. And most of them say similar things to laparoscopy is safe, the outcomes are similar, it's feasible, there are no differences or improvements in length of stay, complications, mortality that favor laparoscopy. There are also other systematic reviews that look at laparoscopy and trauma, and they highlight that it is appropriate for a selected subgroup of patients with particular surgeon expertise. It can be more cost-effective and safe, and again, a reduction of morbidity and improvement of outcomes. The last two articles I just want to highlight comment on the fact that laparoscopy and trauma can be safe and reduce postoperative complications, can avoid non-therapeutic laparotomies, but they do highlight, I think this is really important, that most of the literature is based on heterogeneous observational studies, and there is this need for a systematic stepwise approach to laparoscopy in the treatment of trauma patients. And so for the talk, I'd like to kind of walk you through one of these articles, because I think it highlights the different points that we need to consider when considering laparoscopy for trauma. And that is the why, the who, and the what. So who are the patients that we should treat with laparoscopy, and what are we going to perform on them, where and how to do this safely, what to consider in regards to your setup, when to perform laparoscopic trauma, and then a little bit of technique. I will note that this paper was based on a single attending surgeon with specific expertise in acute care and minimally invasive surgery in a major trauma center in northern Italy. There are some points that I don't agree with them in the article, and as they relate to the presentation, I'll point those out. While this is a very long sentence, I do think that it summarizes things very nicely. So the authors state that certainly a trauma laparoscopic approach should not be undertaken if not by experienced trauma surgeon able to correctly select the suitable patients and deal with the immediate need of conversion to open procedures, but also having advanced laparoscopic skills and being confident with his or her ability to adequately inspect the abdominal cavity and thoroughly rule out potential injuries, and eventually decide either to convert to an open procedure after diagnosis or manage it therapeutically with a minimally invasive procedure. But again, I think throughout this talk, we'll talk about it's the combination of the trauma surgeon, the selection of the patients, and the ability to convert if needed, and the surgeon's ability to rule out injuries using laparoscopy, because obviously we don't want to perform a laparoscopic procedure and then have a missed injury to set the patient's hospital course back. So why do we want to try and do laparoscopy in our trauma patients? Well, we know that the laparoscopy has a lower inflammatory response in open procedures, and patients who have sustained trauma already have a pathophysiologic inflammatory response. And so if there's a way we can mitigate that, that obviously improves our patients' outcomes and their recovery. The laparoscopy allows for diagnostic accuracy with fewer laparotomies. We know that CT scans, especially early in the patient's trauma timeline, have low accuracy for peritoneal dilation as well as mesenteric and hollow viscous injuries. And diagnostic laparoscopy can reduce the rate of non-therapeutic laparotomies up to 73% in some series. Laparoscopy improves respiratory function, often because it causes less postoperative pain. It's associated with less adhesions, less incisional hernias, and decreases the patient's length of stay and hopefully allows for a faster recovery. But there are risks of laparoscopy, especially as it relates to trauma patients. So the risk of pneumoperitoneum and trauma is significant in that it can decrease venous return, leading to hemodynamic compromise. If there is a venous injury because of trauma, it can cause an air embolism. A diaphragmatic injury could lead to a tension pneumothorax. And as we talked about, there is this false negative rate for trauma laparoscopy. Laparoscopy sometimes can take a little bit more time than open procedures as well, which can lead to temperature shifts, coagulopathy, and hemodynamic instability in the trauma patient. So again, it's a combination of patient selection and consideration of surgeon expertise that should guide the laparoscopic approach for a trauma patient. This article out of Italy had a table that listed some contraindications to the laparoscopic approach. They listed absolute and relative contraindications. The absolute ones are fairly standard in that it's hemodynamic instability as well as cardiopulmonary dysfunction that would prevent the ability to do a procedure laparoscopically. Severe traumatic brain injury is also a contraindication in that it can be increased with pneumoperitoneum. And obviously, if you can't tolerate pneumoperitoneum, you can't perform the surgery laparoscopically. The relative indications are a little bit more controversial. Impalement is important because for impalement, often you're worried about blood vessels being injured, and you need to gain proximal and distal control in order to not have the patient bleed out when you remove the item that has been impaled. In a separate area of the article, the authors also note large vessel injury, retroperitoneal injuries, and renal injuries in general should be explored through an open, not a laparoscopic approach. Another article had a slightly different way to think about who to do trauma laparoscopy in. So you have your trauma patient. If they're unstable, they get a laparotomy. If they're stable or a responder, you could potentially manage them non-operatively depending on the injury. Or if you go to laparoscopy, it can be diagnostic, and then you have a couple of different options. You can go right to a therapeutic exploratory laparotomy, or therapeutic laparotomy, or you can continue with the laparoscopic approach in order to treat the patient, again, depending on their injury. The Italian paper also had a table which listed indications to laparoscopic procedures in the trauma patients. And I'm just going to walk you through this because I think it highlights some of the ways that we commonly use laparoscopy in trauma patients today. I would say one of the more common reasons is unexplained free fluid. So if you have a patient who has free fluid in their pelvis, especially a male, and they don't have a solid organ injury, so a spleen or a liver injury, we will often use laparoscopy to try to determine if there is some hollow viscous injury or mesenteric injury. And it's also useful to use laparoscopy when you have a discordance between the patient's clinical exam and their CT findings. Laparoscopy is also commonly used when it's uncertain if the peritoneum has been violated. So especially with anterior abdominal stab wounds, you can clearly see using laparoscopy if the peritoneum has been violated, and then make a decision about if you're going to explore the abdomen laparoscopically or convert to an open procedure. Laparoscopy is also very beneficial in identifying and treating diaphragmatic injuries. The diaphragm, particularly depending on where it is injured, can often be accessed more easily through a laparoscopic technique as compared to an open technique. The authors do highlight several instances of using laparoscopic laparoscopy for splenic injuries. I would say the important thing to take out of this is that it's often just the indication for the splenectomy, not necessarily the approach that has allowed these injuries or these situations to be making this table. And so sometimes there are patients who have very high grade splenic injuries who are going to need to be on the operating table with another service such as orthopedics or the spine surgery service for an extended period of time, and you worry about them bleeding from their spleen. Often, sometimes we will just go ahead and do a splenectomy, whether that's performed open or laparoscopically, to rule out, to take that bleeding out of the picture when they're in these multiple hours spine orthopedic cases. The other place where laparoscopy is very handy is in complex pelvic trauma with low rectal injuries. So in cases where we want to divert the stool away from their complex trauma, we often will bring up a double barrel colostomy laparoscopically. So the next question is where? So where should trauma laparoscopy be performed? The authors state that a level 1 trauma center is the most desirable setting where to safely perform laparoscopic procedures. I take a little bit of qualms with this. I think there are some level 2 centers that would be very well equipped to handle a laparoscopic trauma. It's important to note the main difference between level 1 and level 2 trauma centers is that level 1 centers have a requirement for education as well as research associated with the trauma. There are some other differences, but as it relates to, for example, determining if a patient has a peritoneal violation due to a stab wound, I think most level 2 centers would be able to handle that scenario. But again, it should be hospital specific, level trauma center specific, and highly depends on the surgeon's working environment and team. So not only do you want to make sure that you have your nurses and your scrub techs and your circulators familiar with laparoscopy and the ability to convert to an open procedure should that need to happen, you also want to have your anesthesia team obviously be well versed in laparoscopy and trauma before you're going to pursue this. The next question is when. The authors of the paper have this statement, which again, I take a little bit of pushback on, but when discussing the timing of a trauma laparoscopy, the possibility of doing it at night if necessary versus delaying to the next morning is also a matter of debate. Operating on nighttime is not a contraindication to laparoscopy in trauma patients. However, most of the previously cited indications can be delayed until the next morning. I think most trauma surgeons would say that if you think that the patient needs an operation, it should be done in as soon as time frame as possible, and that in general we should not be delaying trauma cases so that it can be done laparoscopically. So then let's talk a little bit about how you do trauma laparoscopy. You want to have the patient in the supine position, because if you need to convert to an open procedure, that can be done most easily in that position. The authors do not recommend using a varus in trauma patients due to bowel distension. I think that that's something that the individual operating surgeon needs to make a decision about, and about what technique they're most comfortable getting into the belly with. Pneumoperitoneum should be slowly and progressively established. I would say use as at the least amount of pressure possible. Obviously, you need to abort the laparoscopic procedure if you have rises in respiratory pressures, hypotension, and tachycardia. You insert your operating trocars and often insert them in the left upper and lower quadrants to run the bowel, potentially needing to insert additional trocars bilaterally in order to make sure that you can systematically examine the abdomen. And this is very important. So you want to do everything laparoscopically that you would normally do with an open procedure, including exploring the lesser sac. And you often need to use Trendelenburg and reverse Trendelenburg positions to do this in order to move the intestines appropriately to be able to see everything. And so you obviously want to make sure that the patient is adequately secured to the operating room table so that you don't have them falling off the table as you're moving them about. One other trick is that you can prevent CO2 leaking from penetrating wounds using an occlusive dressing over the penetrating wound to maintain your pneumoperitoneum. this paper, which I love the title of When to Start and When to Convert, because I think these are the two major questions. You know, do I need and want to pursue this laparoscopically or start this laparoscopically? And then if I do do it laparoscopically, when should I be converting to an open procedure if needed? And so they outlined this kind of systematic approach to steps of laparoscopy. And it's very similar to what most people have done already in their heads for open surgery. But you access the established pneumoperitoneum and place your ports. You assess the abdomen for bleeding and control what bleeding you can quickly. You inspect the rest of the abdomen. You make a decision about whether or not you're going to stay laparoscopic or convert to an open procedure. You have therapeutic interventions that you perform either laparoscopically or laparoscopically assisted. And then finally at the end, you re-inspect everything one more time to make sure that you haven't missed anything, and then close your port sites. And so just a little bit, one more slide about the how, and reminding ourselves that the how is really determined based upon several elements. And it's the type and the extent of the injuries, the patient's hemodynamic stability, and the surgeon's technique. And so this drives whether or not the procedure can be completed laparoscopically, or if there's some need to convert to an open procedure. Again, I would like to thank SAGE's program committee and the moderators of the session for the opportunity to present on laparoscopy and trauma. I hope that everyone is staying safe, and thank you again for your attention.